Good morning, everyone. Let me present my 9 months progress on my PhD topic, which title is Investigating Different Etiologic Factors of Preterm Birth. I am Eszter Hoffmann, and I work as a resident doctor in the Department of Obstetrics and Gynecology in Semmelweis University. My vision is to contribute to the prevention of preterm birth, and my mission is improving the protocol for the treatment and prevention of vaginal infection during the pregnancy. I have 3 ongoing projects, and let me talk about my first project, which title is Routine Screening of Vaginal Flora During Pregnancy Reduces the Odds of Preterm Birth. We sent a manuscript for internal review last week, and we hopefully can submit it next week. And on the top of our list of journals, we have the Lancet Public Health, and hopefully we can send it to that journal. And the background of this topic is that the incidence of preterm birth is between 5 and 18% worldwide, and we spent almost 8 billion forints for the first 6 months hospital care of the neonates. And on the left side you can see a figure that shows that as the number of the weeks of pregnancy decreases, the chance of the complications and the mortality gets higher and higher. So that's why it's very important to prevent preterm birth. Among the different etiologic factors of preterm birth, there is infection and inflammation, and there is no protocol for screening of vaginal infection during the pregnancy care. And our aim is to see if routine screening of vaginal flora can reduce the rate of preterm birth and prevent preterm birth. The clinical question was that can regular screening of vaginal flora during pregnancy decrease the rate of preterm birth and premature rupture of membranes? The population was pregnant women, the intervention was screening of vaginal flora, the comparison was no screening, and the outcomes were preterm birth, low birth weight, premature rupture of membranes, and the risk factors of preterm birth. And our hypothesis was that regular screening of vaginal flora can reduce the rate of preterm birth. We did the systematic search on the 21st of October, and we found 13 eligible articles for our meta-analysis. And our first outcome is preterm delivery before 37 weeks. And here on this forest plot, you can see that by screening, compared to no screening, we can reduce the odds of preterm birth by 29% significantly. And this means that we can avoid 29 preterm deliveries out of 100. We did subgroup analysis by study type, and here we can see that for the RCTs, unfortunately, we didn't get significant results, but I think this data still suggests that screening can be beneficial in the prevention of preterm birth. And our next outcome is preterm delivery before 32 weeks. And here we can see that the odds of preterm birth can be decreased by 49%, and this means that we can avoid almost the half of the preterm deliveries before 32 weeks by the screening. Another outcome is birth weight under 2,500 grams, which means that we have a low birth weight, and here we can see that the odds of this scenario can be reduced by 36%. We did a subgroup analysis by study type for this outcome as well, and here we can see that we got significant results for the RCTs, and the odds of low birth weight can be reduced by 29%. And our most relevant and most important outcome is the birth weight under 1 kilogram, because these neonates are born before the 28th week of the gestation, and they have the highest risk for the complications and for the mortality, and that's why it's very important to avoid this scenario. And here we can see that by screening we can reduce the odds of low birth weight under 1 kilogram by 67%. And here you can see all of our outcomes, and I was talking about only these 4 because these are the most relevant outcomes from all. And as a summary, I would like to say that the strengths of our study is the high number of the patients, the different type of the screening methods that were examined, and these screening methods were easily executable. And the limitations of our study are the low number of the RCTs, the different type of the treatment protocols, and the pregnancy care protocols in each country where the studies are from. And as a conclusion, we can say that routine screening of vaginal flora can reduce the odds of preterm births. And we found the strongest significance in studies where screening was performed by healthcare specialists. An implication for practice is that the routine screening of vaginal flora is recommended during the pregnancy care and is strongly recommended in high-risk population. And an implication for research is that further RCTs are needed on any type of screening, and the screening methods should be compared to each other. And now let me talk about my second project, which is investigating the efficacy of treatment of abnormal vaginal flora during pregnancy to reduce the rate of preterm births and premature rupture of membranes. The background of this topic is that a common cause of preterm births is infection, and there is no guideline for managing vaginal infection during the pregnancy. And if we talk about the treatment, we can choose oral or local treatment. We can choose metronidazole, clindamycin, clotrimazole, lactic acid, probiotics, or we can say that we don't treat at all because the infection is asymptomatic. And our aim is to see if the treatment of abnormal vaginal flora could prevent preterm births. The clinical question was that can treatment of abnormal vaginal flora during pregnancy decrease the rate of preterm births and premature rupture of membranes, and which is the best treatment? The population was pregnant women, the intervention was treatment, any kind of treatment, the comparison was no treatment, and the outcomes were preterm births, low birth weight, premature rupture of membranes, and the risk factors of preterm births. And our hypothesis is that treatment of abnormal vaginal flora can reduce the rate of preterm births. And the clinical and research implication is that to decrease the rate of preterm births by updating the protocols of treatment of abnormal vaginal flora. And we did the systematic search on the 21st of October, and we found 41 eligible articles for the meta-analyses. And now let me talk about my third project in a nutshell. Its title is Genetic Variation Associated with Preterm Births. The etiology of preterm births is variable, and both maternal and fetal genomes likely affect susceptibility. And different genes can be associated with preterm births, but more examination is needed according to the literature. And we are planning the examination of placentas that were collected from pregnancies with intrauterine growth retardation, preterm births, and from a control group. And we are planning to examine preterm birth associated genes like MBL2 and DFB1. And our aim is to identify fetal genetic variants that predispose to preterm birth. And as a summary, I would like to say that we would like to submit our first paper in June, and the second one in July or until August, and the third project should be submitted in 2023. And to close my presentation, I would like to share a quote from my favorite basketball player who said, "Everything negative, pressure or challenges is all an opportunity for me to rise." Thank you for your attention.
Thank you for your presentation. My question would be, according to the articles which are included to your meta-analysis, which point of the pregnancy, which phases would be recommended to the screening, and how often should we do it during the pregnancy?
Thank you for your question. It was different in the studies. We found that they did the first screening in the first trimester, but in most of the studies they did the first screening in the second trimester between the 18th and the 24th week.
Thank you.
I also have a question regarding to your first topic. As I can see, you are comparing screening with no screening. And does any intervention follow the screening if it was suspicious, just the screening prevented a preterm birth in the cases?
Thank you. It's a very good question. Of course, after they found something during the screening, they started the treatment, or they had a group with the placebo. And our second meta-analysis is about the treatment, because we were discussing a lot about to combine these two PICO together or not, but we decided to separate only the screening and after, of course, the treatment.
Yeah, thank you. Just to clarify it, if they found something in your first meta-analysis, if they found something, they treated it.
Yes.
They were not involved in different studies. So if something was found, it was treated and it prevented preeclampsia.
Yes.
Preterm birth. I'm sorry. I'm just into my topic really. Yeah. So thank you for your answer.
I would have a very simple and practical question, Eszter. What would you recommend if, for example, I make a self-pH measurement at home and the result is out of the normal range? What should I do then?
You should call your doctor and go to your doctor for a visit.
And what will you do?
We will treat it, and there are different treatment protocols, and
how will you treat that?
Sorry, I didn't hear it.
How will you treat? Because it's only the pH level. You cannot really treat the pH level itself.
If the pH level is elevated, we can talk about bacterial vaginosis, and we can give antibiotics for that.
Wouldn't you perform any other examination or test? You would immediately give antibiotic. I'm just asking.
Mm-hmm.
Okay.
Yes.
Rita, there is absolutely no need for any more investigation, because it's absolutely clear. If the pH level is high, then it's a bacterial vaginosis. So you have to treat it either by antibiotics or by local antiseptics or something like that. For example, the pediatricians are afraid of that we give antibiotics systematically, and then they say
probably that's why I'm asking.
Yeah, then they say we destroy the microbiome of the fetus and then the newborn. But therefore, the second meta of Eszter is really very important, which treatment method to choose.
Okay, thank you.
Thank you.